Welcome, everyone, to the World Health Network's Monkeypox Talk. Tonight, we have the co-founders here of the World Health Network, Eric Feigl-Ding and Yaneer Bar-Yam. We're excited to answer your questions about monkeypox and go over everything you need to know to stay safe. We'll start off by introducing Eric, if you would like to come on and just share a little bit about your history and your knowledge of pandemics. Thanks, Eric.
Thanks, Katie. Hi, everyone. I guess we're back at this kind of moment again, in which I'm very worried, and along with many others, and that's why we're hosting this kind of Twitter Spaces chat, which incidentally 2 years ago did not even exist as a feature. So thanks everyone for coming. Yaneer will be here. And I think someone needs to make Yaneer co-host or a speaker soon. But Yaneer Bar-Yam is the president of Nexi and my World Health Network co-founder. And we want to really talk about the state of the world. I haven't been doing as much tweeting as much as I've been sulking over how bad it's getting. And I think the news it's been getting pretty bad that even the CDC and the Biden administration is trying to get more testing capacity, since many states have almost no testing capacity for monkeypox. It's very much deja vu, like January and February 2020 again, when we did not have enough testing capacity for COVID. Remember how hard it was to get the testing back then? It's, and as you know, no testing, no pandemic, no epidemic. Yes, I am on my phone, Katie, if you're asking. So I want to really just have a deep dive when a lot of the monkeypox history with Yaneer. And Yaneer, let's see. I've invited you to speak. I think you just need to needs to accept, so that I'm not the only person here speaking. Katie, can you try inviting Yaneer again?
Yeah. Hi. Sorry for the technical difficulty. I think, Yaneer, you're going to need to switch devices. You can only speak on this app with the phone, not the desktop. So sorry for the delay. We'll have to continue with Eric.
Yeah.
Oh, Yaneer's here. Okay. Thank you.
Okay, great.
All right, Yaneer, why don't we take a few minutes, and if you don't mind, to just introduce yourself to folks that might not know your work. Thank you.
Yaneer, you're muted.
There it is. Can you hear me now?
Yes.
Great. So as Eric said, unfortunately, we are seeing a new outbreak that has grown to the point that it's clearly creating a threat across the world. Big picture, I think that we should become aware that the current conditions globally with transportation accelerating the transmission from places where any place where a disease can start to the rest of the world is creating conditions for rapid spread of disease. And that's obvious. But the implications of it are not yet affecting how we think about the world and how we think about the risks that we're facing on a day-to-day basis. In the meantime, I think people would have been and probably are surprised by the fact that in the middle of the COVID pandemic, we're facing another pandemic. But I think that this is a reflection of fundamental changes that have happened in the world. And when we understand them, we will recognize also that there is a need for us to develop a different attitude about the ongoing risks that we are facing. As Eric said, today we have been observing the growth of the monkeypox cases spreading around the world. And a lot of what's happening now seems at least different from the experience with monkeypox over the last decades. And there are reasons for this that we will obviously talk about today. But the most important thing that we should think about is, what do we have to do? How do we have to think about our own safety? And more generally, how do we have to think about our safety as members of communities and countries and the world? And I think that the most important thing that we have to do in order to be safe is to recognize that passive behavior is not an option if we don't want to be severely impacted by pandemics, and in particular, the next crisis that appears to be arising is the monkeypox outbreak. And so we want to talk about that today systematically, and really the opportunity that we have to prevent harm is the crux of what we should be talking about.
So if we could talk a little bit just about the history, I think a lot of people are wondering, like, is monkeypox new? Where did it come from? And is it different now, or like, what's happening there?
So let me start by saying that monkeypox was discovered incidental to having some monkeys in the 1950s in Europe, but the general prevalence of the monkeypox virus is in rodent populations and in other mammals in Central and Western Africa, but particularly in Central Africa. And historically, there has been a progression. The progression started with the awareness of a few monkeypox cases in the 1970s, mostly in rural areas where there's a lot more contact between people and animals, in villages through hunting and other reasons. But over time, as people became more aware of the disease and likely detected it more often through observation, but also because of urbanization and development that happened in Africa as people moved to cities, the result is that the outbreaks progressively increased. And we've gone in that area of Africa from outbreaks where there was almost no human-to-human transmission. Very few cases occurred to a situation in the last few years where there are thousands of cases per year that are spreading in their area and are present in multiple countries, both in Central and Western Africa. But the primary location is in the DRC in Central Africa. So we have this dramatic change over several decades of progressively larger outbreaks, progressively more human-to-human transmission. And as that happened, there have been a number of cases that have been discovered, found in other countries. In 2003, there was an outbreak in the US that was not because of a human traveler, but rather because rodents were brought from Africa to the US and they infected a number of people. There was very little human-to-human transmission at the time. But then there were transmissions, uh, a few cases of people traveling to the UK, to Israel, to Singapore. Um, and if you look at the progression of the number of cases that are happening in Africa and the number of cases that are traveling from Africa to other places, it's quite pointed that the chances of having a larger outbreak is actually manifest. And there are several papers. There was a new paper that was published just a few months ago before the monkeypox outbreak, but there was also a paper that was published in 2000, in the early 2000s, that pointed at the changing dynamics of monkeypox and the danger of larger outbreaks. So I think that the history itself shows us that we should be concerned about monkeypox. Should be concerned about it traveling globally. And this is a starting point for a conversation about what's happening now, but it is important background to think about as we are aware of the risk of this virus. It's not just a disease that has very little human-to-human transmission, which was true in the 1970s and 80s, but since then, it has become much more transmitting in Africa, and now, as we see, there is a tremendous amount of community-based transmission across first Europe and the U.S. and other countries across the world.
Yeah, and that the cases are really, really growing fast. And thanks for that historical perspective, Yaneer. I want to just point out that we are now on another. I'm losing count. I think that we're past 10 days of record highs in terms of daily record cases, and I think Katie just posted the tweet I just posted around daily confirmed cases, and we're just on day after day for the past month and a half of record-setting cases. Around May 12th, there's basically almost next to no cases globally, and a month and a few weeks later, we are setting records of 180 daily cases now, according to the latest count of the 7-day average. The reporting is very haphazard right now. This afternoon, for example, the U.S., when I checked around lunchtime, there was 141 cases. I just checked again. There's 156 cases cumulatively. So U.S. just added 15 between lunchtime and now, and we don't even hear any news about this. And again, it's
So
because
Eric, where are these cases in other countries?
yeah, most of these other cases are most centered in England is now the epicenter. Portugal, Spain. Spain and Portugal were some of the earliest, along with England. But now it's surging in continental Europe and Germany. Canada has a lot of them, and uh, I can actually pull up the exact numbers, but the numbers are incredibly high, and I can't emphasize how bad it is gotten recently. Um, it's England has over like almost 800, I think. Spain is over 500. Germany is nearing or at 500. The case count updates really quickly. Portugal has fallen to fourth. Canada, France has 183. As of yesterday, U.S. had 115. But as you know, U.S. we added a dozen between lunch and evening today, and the rest of continental Europe, Netherlands, Italy, they're all growing. It's wherever it has landed, it has grown pretty much exponentially. Israel has some, Brazil has some, Australia has some, and many other smaller countries have a lot. And of course, I don't even need to go any further because many other countries just do not have the testing capacity. Even the U.S. does not have the testing capacity. England, as we know, has a lot more sequencing and a lot more testing. And even in the limited testing that we've had, US, we've already established there's more than one variant in the US alone. And they believe it was from independent introduction. And basically, it wasn't just like one bad, kind of like sometimes early on, people think, oh, we just got bad luck. Remember how in Boston in early COVID days, there was the Biogen outbreak, there was a Skagit, the choir outbreak. Oh, it was just some bad luck. But I don't think it is. Because we've already seen multiple successful introductions. It wasn't one super spreading event. Some people, for example, they acknowledge that there was a festival in Netherlands early on, and that it's just people returning a festival. No, this is definitely growing beyond just a single festival. You can't try to deny that. And in many ways, I think I want people to understand that the concern is brewing that this could be another major international emergency. And I think I'm willing to call it, I think, an international public health emergency. And we're going to have an announcement coming up very soon at the end of this talk here. But I think the
Yeah.
WHO is meeting tomorrow around this as well, whether to have discussed a public health emergency international concern. They announced this 9 days ago. We're going to have an emergency meeting in 9 days, which is finally tomorrow, to finally discuss this. And my worry is that many years ago, in early pandemic January days, actually before I even declared my Holy Mother of God, this is going to be a thermonuclear level bad pandemic for COVID. WHO actually declined to declare a public health emergency many, many times. I think they declined it twice. And only after they met the third time did they finally say, okay, maybe this new novel coronavirus from Wuhan is a public health emergency of international concern. And finally, that was done, like, I think January 26th or 28th. You guys can check the date, but it was incredibly late after several punts and deferrals of not declaring it. And I think we're in that kind of phase again where we're kind of playing, footsie with, should we declare, should we not declare? But I think we all know that the lesson from COVID is that not declaring was a grave mistake. And Dr. Mike Ryan of WHO rightfully said later, obviously in March 2020, that, if you want to be 100% certain about something before you act in a pandemic, you'll lose. And I think we're losing badly because the exponential rate of increase, as you can see globally, and this is even with a very limited testing capacity in many countries. I think US, I think in New York, they were just saying you can only get 20 people tested in a single day, is just abysmal.
Yeah.
And
So let me pick it up from there for a bit. I think the critical point is the following. We know from experience and knowledge of smallpox and knowledge of monkeypox how to stop this. And it can be done basically with rapid and effective case identification and contact tracing and an appropriate isolation and quarantine of only a few people, and it can be stopped. And the way to do this is just to really make clear to everybody what the symptoms are, and given those symptoms, give people the opportunity to report their symptoms and be tested. And right now, as Eric said, the capacity for testing is already being exceeded, and that's going to undermine the ability to identify cases. So the longer we wait, the worse it'll get. If we don't respond, if we respond quickly, then we can have adequate capacity, we can have the ability to test. Now, one of the things that's been happening is that people have not been allowed to test, even when they have the symptoms. And the reason for this, if you remember back at the beginning of COVID, The only people that were allowed to be tested for COVID were people who had traveled to China, to Wuhan. And because the idea was that it was only those people that might have COVID. But of course, that rapidly became not the case. So today we have a similar situation with monkeypox. The situation is that the disease transmitted at the beginning rapidly through the gay community, through events, pride events, and those events spread, of course, within a particular community. But monkeypox is not specific to that community. And the spreading across the world provides now the opportunity for many people to be infected. And what we have now are in many places conditions where only people who have either traveled to Africa, where the disease has been present over the last decades, or people who have um, specific identified contacts who have the disease identified already, or people who are members of the community of gay and other men who have sex with men are being allowed to be tested. And of course, what we're doing is we're exactly precluding the discovery of cases that would enable us to prevent the transmission, to broaden out into the community as it broadens out into the community, and be able to stop it. And that, of course, will undermine any efforts to control the disease. And also, of course, as it's clear, it's underreporting the disease. So what we're seeing is tremendous underreporting and undermining of the ability to prevent the disease. Go ahead, Eric.
Right. And the symptoms I want to emphasize are early on. It's very generic. It's some rashes, and some soreness and tenderness, and it's so similar to many other STDs early on that many people might not immediately realize it's monkeypox. So, like, you've seen some photos of like giant boils of, like, for example, smallpox and monkeypox. Yes, theoretically they can happen, but rarely do they get that big. Um, and oftentimes they're just small, like a bite. So they look like, oh, did I get bitten by an insect? But this thing's starting to itch. I have a rash here. Oh, it was a poison ivy. It's very non-specific. And especially in the summertime when people are outside, you can easily get poison ivy and rashes and many other things. And by the way, I don't. Yes, early on there was a lot of spread among LGBT MSM men, but I don't think like there's a lot of gay men now who are being testing positive, and I think, by the way, they're stigmatized a little bit because they actually have a lot of gay men have actually access to a lot of testing, and they're much more cognizant of a lot of these kind of STD type of rashes that could be syphilis, herpes, and whatnot. So I think in many ways they get testing a lot faster, and we've seen this kind of phenomenon in public health before. Populations that are heavily monitored or aware of other similar diseases that can bring about something are tested faster, and hence we have an overabundance of testing early on for this. And the other thing is the incubation, according to Dutch outbreak, has an average incubation of, say, around 8 or 9 days, but it has a huge range. The 95% confidence interval goes up to 2 weeks, but then there are cases in which it goes up to 20 days. So the incubation time is much longer than COVID.
Let me pick up the symptoms and go through it. Because what Eric said is right, of course, the incubation period is longer, but the symptoms are the classic progression of the symptoms is through early standard flu-like symptoms with fever, headache, cough, muscle and back pain, fatigue, and chills. So you wouldn't know it as being this particular disease. But one of the fairly unique early symptoms is very swollen lymph nodes. So if you have swollen lymph nodes, it's definitely an indication that one should be tested. And then, of course, there becomes a rash. The rash may be weak, but it also may become strong. And once it becomes strong, it actually becomes quite painful. And the painful period could last for a long time across these the bumps going through these spots going through like pimples and then blisters, and then they become abscesses, and then eventually they scab and fall off over a substantial period of weeks. Go ahead, Eric. If you
Yeah,
how long are people sick for?
It's
how long are people sick for?
2 to 4 weeks. So the whole period of time that someone can be contagious can extend from 3 to 7 weeks. But it starts with the early period of the symptoms, and then extends through multiple weeks of the progression of the rash.
Yeah. And I think the isolation time, if you're positive, like Singapore is implementing 21 days of isolation. This is much longer than COVID's isolation of standard of 10 days or 2 weeks in some places, right? And like, for example, there was a British Airways crew, 11 members of a British Airways, I think, of a large jumbo jet that landed in Singapore, tested positive. The whole crew is now being forced to isolate for 21 days. And although we don't know exactly about asymptomatic transmission, it's one of those early kind of like fog of war things. Like COVID, early on, we were debating, is there asymptomatic transmission? Many people said, oh, there isn't. Don't worry about it. Unless you have symptoms, you can't transmit. And then people say, well, you don't know that. And it's like, well, we just have to assume that that's true. Hence, you don't need to mask until you have symptoms. And obviously, we know how wrong that was. And I think that led to a lot of spread in the early days. Remember, early action actually will prevent a lot more cases from cascading. And I think we're making the same grave mistake again. I think even if there's not much asymptomatic transmission, and by the way, COVID turned out to be hugely asymptomatic, as we know. 40 to 50% of all cases were asymptomatic transmission related. And of course, let's not even get into the airborne issue for how airborne COVID is. Now, I think we should take the precautionary principle. Like some people say, oh, this is the fear mongering. I think people have called me fear mongering for years now. And I have never been ever trying to fearmonger, but just people don't understand the concept of precautionary principle in face of a new virus that clearly this monkeypox is light years different than many other previous monkeypox outbreaks. And we know that the population immunity is very low. Basically, if you're born or you're raised after early to mid 1970s, you do not have the monkeypox. You do not have a smallpox vaccine to partially protect you. And monkeypox vaccine is still very, very rare, and so the population immunity is pretty low. And I think we should assume that there is some degree, maybe not primary, but at least some degree of asymptomatic transmission. Because early on, if you're wrong, you know what, we may have taken a little too much, but if precaution, but if we're right, that and we actually protect people, this could actually stop this virus from spiraling. And right now, clearly the virus is already spiraling around the world and spiraling out of control. I think that honestly we've hit that turning point where we've lost control of this outbreak already.
Yeah. So
And WHO already kind of acknowledges that. I think that the opportunity to keep it under control, that window is already closing. And I think that's just a euphemism for saying that they're admitting that there's some sort of containment failure here. Clearly,
so let's go through. Let me go through what we really need to do in order to contain this. And I think this is again, the point is the following: the reason to raise an alarm is not because we want to be worried about it. It's because we want to solve the problem. If we solve the problem, we don't have to worry about it. That's the whole point. So there's no reason to think about it as fear. The reason to think about it is a call to action. We need a call to action that's clear. We need to clarify what it is that we should do in order to stop this pandemic, the new one, the monkeypox outbreak. And I think that we can go clearly talk about what it is that is needed to be done. And the point is that it's actually very practical steps. So, number one, we need widespread public communication about the need to identify cases and the symptom and really articulate what the symptoms are, as we just did. The fever, headache, cough, muscle and back pain, fatigue and chills, the swollen lymph nodes that can be a signature of this disease in comparison with many others, and the rash that develops. It generally starts on the face, or often starts on the face traditionally, but it can, some recent cases are starting on genitals or in the anus, but they spread to other parts of the body, across the chest, in the palms of the hands and soles of the feet, and even inside the mouth. And again, it can be painful, and it causes scarring, and it goes through this sequence from spots to abscesses until they finally fall off. The second thing that we need to do is make testing available. As Eric has explained, definitely we're not going to stop this unless we identify cases, and testing is critical. And if we have to have the testing available to anybody who might have the disease. Otherwise, we're just stopping, a few of the cases and not the cases that we need to stop. And we need to have clear information about where testing is available and the importance of testing. And we need to make sure that there's information about the need to isolate from others where there are symptoms, even before the confirmation of the diagnosis, so that people can stop infection right at the beginning. And then we need to make clear, as we've said, that it is not just infection within the gay community. We know that there are challenges associated with having misunderstanding and stigma that would lead people not to report their symptoms and not be tested. So we have to be very clear with everybody around that anybody can get infected, and that if they have symptoms, they should be tested. And then there is need for making sure that people who are infected or confirmed infected, or people who have those contacts, have the ability to prevent transmission through having accommodations that will provide them with both the space, a good space that they can be for the necessary time, and receive the necessary medical support, of course. And this may often include the need for key financial support to people, to make sure that they're supported during the time period where they have to be isolated or quarantined. And then there's one final thing, which is that if there are outbreaks, specific local outbreaks, there's a tremendous opportunity to use ring vaccination, localized vaccination of people who are exposed. There are challenges associated with it, with the vaccines that are available, their availability and the side effects. But there should be plans made to make sure that those can be used in case that's needed. And if we do all of those things, and those things are not huge in terms of what a public health response should be, then we don't have to worry about this outbreak. And again, the main thing above everything else is case identification, so we know where the cases are. And anything that we do as in public health that undermines our ability to identify cases has to be rapidly eliminated. And we really just need to make sure that we identify cases rapidly so that we can stop this outbreak.
Yeah, and I think obviously testing early on is incredibly, incredibly important, or else we're literally driving in the dark without headlights on, and we're only ever seeing cases pop up. It's kind of like right now, it's like looking at the stars in the sky. The light that you see from many stars was, from either thousands of years ago, millions of years ago, or in some cases billions of years ago. And I think we're kind of like racing around, chasing oftentimes these cases that had the infections had happened about well over a week, if not 2 weeks ago. And during that time, it's already spread way beyond just their immediate community. And right now we have so little mitigation, to be honest. I apologize for my long COVID cough that from my COVID back in April, and I still have it. And I promise I'll talk COVID to the minimum today, but we are really, really playing catch up right now. And I think some of the CDC guidelines, some of you may have seen that. I got a little upset last week about some of the CDC guidelines on. It's not that all of them are bad. It's just some of them were non sequitur. They did not make sense. First of all, it says, please try not to have sex if you believe you have monkeypox or if you're close contact with monkeypox. But then it put it under a paragraph of how can I reduce my risk of monkeypox during sex, which is, how that's framed is really weird. And then, of course, where do I go now? They said, oh, if you do have sex with, with your clothes on, but then of course it says, do not share linens, or with other people, which again doesn't really make sense. And of course, given how much of this is we believe is sexually transmitted or very, very close contact transmitted, and there's a lot of lesions that are genital or anal, as we know, that they don't have any guidelines around condoms. And condoms is pretty much bread and butter for most sexually transmitted diseases, but somehow they're not calling for condoms, which does not make sense whatsoever. And I don't know what universe that makes sense. And I think privately, I think some people have acknowledged that, yes, that was wrong. And WHO even is doing outbreak investigations around transmission via semen, because they've already found the virus in semen. And in Germany, they've also found one potential case that was potentially transmitted in that way. So I think, and that, by the way, was over a week ago that happened. It wasn't just, newly discovered and CDC needs to update. No, CDC should have known about it. If the WHO knew about it, CDC should have known about it. Basically, CDC should know better. And I love the CDC. I have many friends there. CDC is the supposed to be the city on the hill in terms of gold standard public health guidelines for the world, in which many other countries, smaller countries, rely on to kind of like copy the CDC guidelines. But it's now, I'm very frustrated with it, to say the least.
Let me say a few things about the CDC, and then I want to talk about a couple of the extraordinary risks that we're getting into right now by not taking the measures. So first of all, I agree with Eric. I actually think that there are a few things that indeed the CDC did quite well. There was a paper that was published about monkeypox and about the current conditions that said they were ramping up testing, that they were ramping up the opportunity to vaccination. And that sounded very good, but of course, we're not seeing that the adequate follow through, and hopefully that will be done. But the point that Eric is making is that the goal of the public health measures has to be to prevent transmission. And if you don't articulate clearly to people what it is that is necessary in order to prevent transmission, and you give people guidelines like putting on clothes or other guidelines that they did, and those are just going to get you infected, then you haven't done your job. And so the point about the guidelines really should be to make a clear delineation of it isn't true that you can just do a little bit of risk reduction when the choices that you're giving are all going to just get you infected. And so So we have to be honest about the consequences of the actions that are being taken. Now, I want to talk a little bit about two specific extraordinary risks that are being taken right now by not doing the right thing in terms of stopping this outbreak. Now, as we've talked, many of the initial cases have been in a particular community, but the upshot of that is that most of them are adults. And by the fact that most of them are adults, the vulnerable population, which is particularly children, have not been by and large infected. And if we allow the cases to continue to grow, there is no doubt that children will be infected, and children have much more severe cases and much higher fatality rates. And we don't even actually know
Yes.
exactly, because the statistics are not good enough, but for the more severe variant in Africa, where the mortality is about 10%, children die at a
That's
50% rate, about, to the best of our
yeah. That's the
that's
Congo
the
variant. That's
now the
the
one that we
yeah. But
have has lower mortality. The data says that it's 3.6%, and people are reporting it more like 1%. But the point is that children are um, are are known to have much higher impact of this disease on their systems, and not just through death, but also through blindness, and of course there's scarring as a result of these the rash, these abscesses, and so the impact on children is tremendous. And so far, we haven't had that because of the specific population that this is in. But if we don't stop it now, that's going to become a major issue. The second thing is that we're at a precipice, and we don't know whether we've passed it yet. But I think we can hope that we haven't. The precipice is that rodents in Europe and in the US will become infected by this disease, and then we will have urban rats all over the world who are infected and are transmitting it to people, just like it has been present in Africa over the last decades. And the challenge of preventing that transmission will be on top of everything else that we're doing on a day-to-day basis, in terms of ensuring our own safety. And as we know, rats are all over the world in terms of their urban populations, and mice are everywhere, and squirrels and so on, and all of these rodents almost surely are carriers of this, can be carriers of this disease, and that's before we start talking about pets. As far as we know, this disease infects widely mammals across many different species.
yeah, I think once it enters the animal population, I think it will be even a greater problem, especially since we know it can from experience in Africa. And obviously, people say, well, some of these fatality rates are much higher in Africa because of, the poor healthcare system there. Yes, that could be true. But remember, in certain ways, the same people who had also said Omicron was mild, I think many in the audience know what I'm talking about, that Omicron is mild. Something can be milder or, less severe. But if you have runaway transmission, the runaway exponential transmission always swamps out any benefit of something being milder. And again, Omicron wasn't that much milder once you adjust for, infection, previous infection, and previous vaccination. And Omicron is much more severe in children. Like more children died post December 2021 in the Omicron wave than had died in the preceding 2 years combined with COVID. And again, runaway transmission almost always swamps out any intrinsic severity once you add up the cases. And especially in children, here it's actually, in many ways, it's inverted because it's more severe in children, and the immunity is also lower in young people because a lot of the elderly population are immunized against smallpox, which is the close cousin of monkeypox. And the efficacy traditionally has been like 75% efficacy, but we don't know exactly about waning over time. And the CDC says that even if you were previously vaccinated against smallpox, you will need a revaccination with monkeypox vaccine. But a monkeypox vaccine, unfortunately, is still incredibly rare and just short in supply. I think the Biden administration and many other countries are trying to ramp up the production. But I think the problem is, it's going to take months. We don't have months at this rate of growth right now. And people are debating, should we use our 100 million doses smallpox vaccine stockpile? My answer is actually no, you don't want to use the smallpox vaccine for monkeypox unless it's some really horrible emergency, because everything that anti-vaxxers say about vaccine adverse events, what they're actually talking about, first of all, the anti-vaccine notion has really gotten off the deep end, but some of the things that they talk about, vaccine severe side effects, that's actually the smallpox vaccine. The smallpox vaccine is incredibly harsh. And if we use it on a large scale among tens of thousands or 100,000s or even millions of people, the adverse events we would have today in today's social media atmosphere, compared to back in the day, is it's not something we want to be using in our general population today. Trust me, especially since a better vaccine does exist, but that ramp up takes time. And the traditional way, people ask, how did we stop smallpox originally? Well, traditionally, rapid case identification, keyword on rapid, and then they did a ring vaccination around everyone, because unlike COVID vaccine, the smallpox monkeypox vaccine has efficacy in the early days of infection or close contact. So if you just got infected and you got this vaccination, it is still have really good efficacy to prevent you from getting a severe disease or severe outcome, and preventing anything, major symptoms. And so in certain ways, monkeypox is easier to deal with that way, that if you identify the cases, you can quickly ring vaccinate everyone around them. And traditionally, that's how smallpox with the ring vaccination approach was stopped, as opposed to, blanket population vaccinations. But that requires two things: rapid testing and identification, and rapid deployment of vaccines in a ring vaccination approach. And the CDC says they have been doing that. There are limited doses, and they have been doing that, but clearly it's not fast enough. This ring around the main case that we just identified is not being formed fast enough. And that's why cases are just still exploding. We have such a lack of testing, and I think we're in trouble. I think we really are in trouble in some degree. Now, whether or not it's airborne, to some degree, yes, it's less airborne, but obviously there's lots of studies that it is potentially airborne in many experiments, and many older studies. WHO actually had a memo that was put out yesterday that actually says monkeypox is airborne, and then today they deleted it. Interesting. CDC previously, for its monkeypox vaccination travel advisory, said you should wear masks, and then they deleted it like 5 or 6 days later, which is interesting. So there's right now this downplaying of airborne and this downplaying of the need of masks. But they do acknowledge droplets, right? They do acknowledge respiratory droplets. And so even if they try to deny airborne, which some you can debate whether or not it's really airborne, but even if they try to deny that, they do acknowledge respiratory droplets, and masks do work against respiratory droplets. And I think it's a grave mistake not to mention masks on the CDC webpage. And I hope they really do a 180 on this. And I expect that at some point in the future, they're going to say we need masks for monkeypox. And at some point in the more distant future, I think there will be some acknowledgement of potentially transmission beyond 6 feet, which it would be a tacit admission on airborne. But, the arc of the moral universe is long, unfortunately, as we learned from COVID, oftentimes it bends too late. And this is always the mistake we're making, that we're always trying to, oh, don't worry, don't panic. You know, true,
Yeah,
you don't
sure.
want to, you don't want to stampede, but I think people need to see the smoke even before they see the fire and be warned of the smoke even when we're not sure how bad this fire is. And I think right now it's becoming clear the fire is getting pretty bad. And this is why we're putting out a declaration in the next few minutes. We're dropping it around 9 p.m. And of we're the World Health Network is declaring an emergency. We're acting. We're asking countries to act, and I hope to God that the WHO at their emergency meeting, emergency quote unquote, 9 days from originally set, will declare a public health emergency and does not make the same mistakes as it did in early January 2020, when it punted on the public health emergency several times before they finally declared it. Because acting late oftentimes is one of these classic trends that we've been noticing, and I hope we don't repeat it.
So, just to review, the best ways to protect ourselves, if we're protecting ourselves from COVID by washing our hands and wearing masks, that's going to be helpful. I also heard that the monkeypox virus is not as easily broke down, meaning regular soap and water might not work, and we have to use hand sanitizer. Can one of you speak upon that concern and how it's
Sure.
different on surfaces compared to COVID? Because we've all gotten used to the protocols with COVID.
So there are two issues. The main thing is that you know the uh, again, the airborne transmission, we understand how to stop. We understand it through masks and ventilation. We know that clean air is the answer to airborne transmission. Droplet transmission, you have to have masks and you have to worry about surfaces. And with monkeypox, because of the um, nature of the pox, it is widely understood that the pox are able to transmit by contact. And the challenge there is that the virus is much more robust as a molecule than the COVID molecule. So it lasts for much longer. It lasts much longer in the air. It lasts much longer on surfaces. And that tells us that we have to be very diligent about actions if we are in a place where we are being exposed to someone who has an infection. And the point that Katie is making, that we have to worry about surface contamination, is that because it's more robust, soap, as far as we know, does not break down the virus in the time frame that we would normally wash hands, and even significantly longer. So what we need to do in this case is to use either alcohol, 7% alcohol, or we need to use bleach, diluted bleach at 1 tablespoon per gallon. These are standard, not specific to monkeypox, but they're understood to kill many pathogens, and it is believed that monkeypox is in this category. There are some, but very, very limited experiments, and really there needs to be a lot more studies. But the bottom line is, as far as we understand for right now, 70% alcohol and 1 tablespoon per gallon of bleach can disinfect objects, surfaces from monkeypox virus, and that becomes the new standard, where soap and heating were previously used for COVID, along with alcohol and other disinfectants. Now we have to remove the soap as a disinfectant, as a primary disinfectant, from the list.
I
Yeah,
also
I think
heard, thank you, thank you. I also am more worried about something else regarding immune system. So we're hearing a lot now, for those that have been paying attention to the COVID news. Once you get COVID, your immune system actually is weakened, right? So I'm just concerned about these two, the interplay between getting exposed to monkeypox and then having to fight off monkeypox after many people are getting COVID, their immune systems are weakened?
Yeah, this is a very good question. It's a good concern because we think that, for example, the unexplained some of the hepatitis in children that we've been seeing is due to COVID and some sort of immune weakening due to COVID. There was a while some people were saying it's adenovirus. We're seeing the adenovirus, but then we're not actually seeing as many there's no adenovirus pandemic of adenovirus 41 as there is COVID. Some people say it's foodborne illness, but again, we're seeing this across many different countries with many different food systems. So I think there is a lot of evidence that the COVID has weakened our immune system, and I think, for example, the UK report just released today about 2% of young children and 5% of teenage children, older children, have actually long COVID, and that's from a national survey in the UK. And I think that's really worrisome if you think about the prevalence of that growing. Basically, we've just exponentially increased our semi-immunocompromised population. Now, obviously, many people do recover, but the issue is, of course, this susceptibility. Every small barrier you remove to transmission, right? It in a supercharged state in which monkeypox is now spreading. Every small little speed bump that you remove is actually going to fuel to the rise a lot more. And I really hope that, as you know, the long COVID in adults has gotten really out of hand, and I think there's a lot of disabilities and a lot of workers unable to work because of long COVID, and I think that kind of disability and weakened immune system could exacerbate this. To what degree, we don't really know because we don't really have the data on monkeypox and long COVID interaction yet. But I really hope that it doesn't get
earlier,
worse.
Eric or Yaneer, you said earlier too that the death rate in children is more likely with monkeypox, which again we're not used to thinking about, with the current pandemic with COVID. So now we're talking about weakened immune systems because COVID's spreading through schools and classrooms like rapid fire. Then we're talking about, on top of it, even in a non-COVID world, a child is more likely to have a severe reaction and possibly die. So this sounds very scary, all this piling on.
Yes. I mean, the problem is that the problem with assuming the best is that, you're likely to be disappointed. And the challenge is that, again, there are many ways that things can get worse, and we've seen them with COVID. At the beginning, people thought that it was just a respiratory disease, and then it became a systemic disease with cardiovascular problems and brain damage, and all kinds of other events. And now it's quite clear that long COVID has a high mortality associated with it, as well as the long-term disability. And so all of these things are showing that it's really easy to underestimate the consequence of a disease. But again, the main point is the following: recognizing that is not the solution. The solution is realizing that we don't have to do it. We don't have to go there. It's much better that we don't have to know everything there is about this disease through decades of experiencing it. The way not to do that is to take a few not so difficult actions now so that we can prevent it. And in order to do so, we need to work together. We need to influence and call the public health authorities and the local governments and anybody else that can act. But the main thing is we need to spread the word that action is possible, that we do not have to live with this disease. The monkeypox can be stopped with relatively simple actions. Smallpox was eradicated. Monkeypox can surely be stopped, but we have to give it our attention and make sure that we do so.
Yeah, and that's why we really want to focus that we need to declare a global pandemic emergency. And I think we're putting out this press release, and Katie, you can pin it to the top of the feed if you want. But basically, given what we know now, I think it's really urgent that countries recognize monkeypox is an emergency and is an emerging pandemic, and we have to act much faster than we did than several years ago with COVID, where we didn't declare a pandemic until mid March of 2020, and public health emergencies were not even declared for several weeks after the initial meetings and discussions about it happening. And so I really, really hope that other countries and other organizations recognize this as well. And we're willing to take some questions. I know we're up on our 1 hour, but I really want people to really understand how serious, and how concerned we are about this, and how countries must mobilize. So, with that, maybe we can take some questions, Katie and Yaneer.
Yeah,
Please.
sure. We have Dr. Mo, if you'd like to go ahead with a question. Thank you.
Hello. Thank you so much, everyone, for the nice talking about the monkeypox. Actually, I want to just only, I have a question. Now, if someone has got a chickenpox in his previous life, so in terms of natural immunity, how he is protective against monkeypox? Thank you so much.
So, Eric, I don't know if you want to take this, but basically, we do not have information that would indicate that chickenpox infection provides protection from monkeypox. The only the family relationships include smallpox, monkeypox, and cowpox, and a couple of other ones, of course, but not chickenpox.
Yeah, they're not related. They're not related. Like cowpox is related to smallpox, is related to monkeypox, but chickenpox is not related. And I think the main thing is that there is an older generation that is immunized against smallpox. Or if you live in developing countries, many developing countries continue to immunize against smallpox until the mid to late 80s. For example, I was originally born in China. I have the smallpox vaccine, but I don't think it's reliable in terms of how much total protection there is. Theoretically, 76%, but I think there's a lot of data that shows there's waning over time, and it's not recommended to rely on it. That if you, for example, became a close contact and they approached you for a monkeypox vaccination, they would definitely, without hesitation, make you give the monkeypox vaccine again. So this revaccination is definitely something that will need to be done. You shouldn't rely on it too much. There is some degree of population immunity. It's kind of like how I say, treating with oh, I was previously infected with COVID. Oh, I should be immune, right? Well, I always say, well, it depends on what kind of dose you originally got. It depends on how immunocompromised you are. It depends on how much waning of your immunity there has been, and of course, it depends on what new variant of COVID there's emerging. So, and I think it's clear that this new monkeypox is definitely a new variant. There's detecting several variants worldwide. The U.S. variant is a combination of the Portugal variant and another descendant of a previous Nigerian variant that came several years ago. And again, you should not assume any previous immunity, and it's just unreliable, and it's too dangerous to assume that. So who's next? Jonathan or?
Yeah, we have Lim is up.
Okay, go ahead.
Hey there. Not so much a question. Just wanted to point out something you had said about immunosuppressed individuals. There was a study. I took the liberty of making a thread on it. regarding the immunosuppressed fatality rate from a study in 1973 that it could be up to 48%.
Yeah. So that's super important. And just to make clear, one thing that we wanted to say, but really is important to say, is that there are really three populations that are high risk. Again, children, pregnant women, and immune compromised people. And one of the things that's been said for a long time is that the population of immunocompromised people has dramatically increased over the last decades, and so we have a very vulnerable population overall. But of course, it's specific people, and we have to make sure that we are attentive to protecting vulnerable people. The consequences, as you point out, can be extraordinarily severe. And thank you for pointing that out.
Thank you.
Thank you.
Yeah, next we have Jonathan, if you'd like to ask a question. Thanks.
Yeah, sorry, this is the first time I've used this system, so I had to give it permission to talk on my phone. So I have a kind of personal question, personal worry, I don't mind saying, which is that we're seeing a lot of talk. You hear the 1% CFR number, and I think that's too low, but you see the 3.6% number for the West African clade, and then you see a higher number for the Central African, I'll call it, clade. But we're seeing a lot of messaging around, this isn't a big deal. And so I wanted to start a discussion or ask, are we maybe doing ourselves a disservice? Because when I pulled, there's a recent article, 2022, by I think an Evelyn Bunge, I'm probably mispronouncing that. It's an excellent summary of all the numbers. But if you look at that CFR number of 3.6, it has huge confidence intervals, which for anyone listening means that the 3.6 number is derived from very few cases. And it actually ranges from 1.7 to 6.8%. And so I just wanted to say, and even when I checked now on the WHO website, one of their pages, the most recent SITREP, actually says a lower case fatality ratio of under 1%. Are we doing ourselves a disservice on this response when we keep downplaying what could be a very serious disease? Because my feeling, it's not a trick question, my feeling is that leads people to sit back and not be worried when worry would actually be a good thing, because worry causes people to prepare and causes things to happen. So I wanted to just throw that out there and ask what you thought.
Yeah, I agree with the general philosophy. That's what the precautionary principle is, and chance favors a prepared mind, as they say. So why I really feel is like there's a lot of these numbers. By the way, in our about 3 decades of understanding monkeypox, most of the data comes from just 2,000 total cases that we have epidemiological tracking data of. There's obviously more, but we already have like approaching almost 4,000 cases of monkeypox now. And we in 1 month, 1.5 months, we have more cases than over 30 years. And I think it's a new variant. But I think we should not assume that what we have now is the same as before. In certain ways, it could be milder, but it seems to be much more contagious. But I think we should, again, be more precautious because a lot of the estimates are really old, and they were done in under testing, situations in West Africa or in the Congo, where there's for example, I'm not sure if the 10% CFR is real, given how little testing there is in the Congo. More people could have been infected, but we just don't know. Again, we should not assume what we have is anything like we have before, because it's clearly not anything that we've had before.
And again, one of the real challenges that we're facing is that the current cases are in a very limited demographic of the population. And we surely will not know what is the general impact of the disease until, at the very least, as we've mentioned, immunocompromised, pregnant, and children are infected. And why should we wait for that to happen in order to get the science done? We really would, I mean, as scientists, science is interesting, but in the context of harm, you first stop the pandemic. And if you want to do research afterwards to find out what's going on, we'll do it using IRBs and figure out what's the way to understand the disease. But we do not have to take the risk, take the harm that will happen out of having people be infected as a motivation, or the fact that we don't have the knowledge right now, assuming that it's going to be fine, and finding out later that it's absolutely not fine. So in the meantime, the imperative is we can stop this. We don't have to worry about it if we stop it. If we don't stop it, we will have to worry about it. And we're likely, in fact, to find that it is severe, even if it's less severe than what was found at some point in time with some variant. There's always many opportunities, including both the acute phase and the current consequences with other effects that we've seen, how this works with diseases. Now we've gained some experience with it. This is not unusual. There are many diseases that have long-term consequences that we have to understand as being intrinsic to harm that can happen with a disease.
Well, thank you, Yaneer. I'm going to move to the next speaker. There's quite a few people that have requested, so we're trying to take an order of which I've seen these pop up. So Linnea Bott,
Hi.
MPH student. Go ahead.
Hi, I apologize if this has been covered before, but I'm wondering if wastewater monitoring is a possibility with monkeypox.
I think so. I'm not sure if anyone has started monitoring on a regular basis. So unless you monitor on a regular basis, I'm not sure how reliable it is, unless we do it systematically. But I'm sure it's possible. They did it in polio, for example. I'm not sure if many of you saw that UK declared a national incident regarding the sudden rise in polio virus in the wastewater there. So wastewater is, I think, one of the most reliable methods. But I do think we're still too early on monkeypox to track how much virus there is in the community today. I think we're still low early, but low and early is the best time to curb the virus. So hopefully we'll have more data on that soon.
Yeah.
Thank you. We're going to take another question from Herpes Advocate.
Hi, yeah, thank you so much. So I'm a patient advocate with an organization called Herpes Cure Advocacy. We're a grassroots membership-based advocacy organization with a goal of cure, treatment, and prevention for herpes types 1 and 2. We have a medical advisory board with some of the world's leading experts in herpes and infectious disease. We work with Dr. Larry Corey and Anna Wald and others. So I just wanted to, for a minute, kind of take a step back and provide some context and just look at things in context in terms of our public health response to infectious disease. Herpes is an infection that in the US, HSV1, which is typically oral herpes, impacts 1 out of 2 Americans. HSV2, which is traditionally genital herpes, impacts 1 out of 9 Americans. If you look at the numbers in terms of monkeypox, just comparatively for discussion, monkeypox in the US, the numbers, I just checked the CDC website, they say there's 155 cases. So if you're thinking about it, okay, perhaps that was since we've been tracking over the past month. Let's just even double that for conversation. Say it's 300 cases.
Let's talk about it, because I hear where you're going with this. But
yeah, I just want to point out that
is,
in the U.S. there's in a month, for example, 50,000 new cases of herpes. Herpes is not benign at all. It also, can be fatal in immune compromised people. It causes infection in encephalitis. It can cause Bell's palsy, which is a form of So
Yeah,
Okay, so I was just
just to
wondering about.
take a step back, I just wanted
yeah,
to
but
ask if
we
we
hear what
thought
you're
that
saying. But yeah, but here's the
there was also a reason for, the World Health Organization to declare, a case of emergency, or like how we're approaching this
yeah.
infectious disease in monkeypox, and if it's potentially uh, something that's just being hyped up by the
Okay.
media because it's like the new shiny object.
So here's the
Let's
answer.
respond to
Real.
that. Yeah.
Yeah. So happy to respond to it. There are surely many public health challenges that we should address. But it really is important to understand the difference between an exponentially growing set of cases where we had smallpox for many years, and there were hundreds of millions of people who died from it. And we know what it looks like to have it, and we took it upon ourselves as a society to eradicate smallpox through tremendous efforts. And monkeypox has, right now at least, is not as severe as smallpox. But even if its fatality rate and even if its consequences are less than smallpox, to allow monkeypox to become a widespread disease without acting to stop it would be recreating a life and an existence in the world that we worked very, very, for very good reason to stop. And I'm surely in favor of taking very strong action, and I know that there are many actions that can be taken to stop other diseases, including herpes, and we would be very happy to have your participation in the efforts of public health that we are involved in. However, to compare um, the level and harm that is happening at a particular time is not ever the point of understanding why pandemics should be addressed. And we've seen that with COVID, and we had all of these comparisons about how COVID is not as bad as driving or a risk or whatever. Those are statistical, static comparisons that do not take into consideration the exponential growth and the resulting harm of the disease that we've seen with COVID, that we've seen with smallpox, and that we sure hope that we won't see with monkeypox. Thank you.
Thank you, Yaneer. We have another question from Vax Fives.
Hi, thanks so much for having me. My big question is for the parents out here. What should we be doing to protect our kids from monkeypox?
Again, the challenge, Eric, you can take it if you would like. I can start, or you can do it. Go ahead.
Yeah, go and start.
So the point is the following: we must recognize that children are known to be much more vulnerable to monkeypox. Right now, and again, for the more severe disease, it's about 50% plus or minus an uncertainty that's quite large. And for the less severe disease, the children account for the large fraction of deaths, and some even say most deaths. So if 3.6 is the estimated value, and most of those are in children, then you know that it's a very high death rate. So the point of being aware of the problem is that we have to prevent transmission. The problem with preventing transmission, if we don't know where cases are, it's hard. You have to take tremendous amount of precautions in order to protect people, right? This is what we've experienced. When we don't have an identified set of cases, then we have to do everything as if each person that we might encounter is themselves a carrier. Now, of course, with monkeypox, because we don't know that pre-symptomatic people are infectious, what we would have, the minimum that we would want, what we could do, is just ask everyone if they have any symptoms, because they can start with just regular cold symptoms, and make sure that we do not get into the same space for airborne transmission, do not touch anybody who has basically any kind of symptoms. And if we want to take the risk of the first few days where someone has, sort of the the non-specific symptoms, then you would basically have to ask everyone, do you have a rash anywhere on your body? If you do have a rash, we shouldn't get together. That would have to be the way we would protect children. But this points to the fact that it's very hard as individuals to take action in the context of a pandemic. So what we have to do is we have to get together in communities. That's the way to do this. But in the meantime, I've tried my best to outline what we need to do. But the important thing is to get everyone the information, particularly everyone that you know, all of your contacts, let them know about the symptoms, contacts in the traditional way, i.e. not people that you're touching physically, but people that you might get together with. And let them know that it's really important that everyone watch out for monkeypox symptoms, have the list. If you have any of these, please go get tested so we can prevent transmission.
Yeah. And I think in many ways, monkeypox in certain ways is opposite of COVID in certain ways, where it is much milder in adults, especially the adults who are old enough to be vaccinated. So you won't hear many deaths or hospitalizations amongst older adults. As opposed to COVID, most hospitalization deaths were in older adults. But here's, again, the runaway situation. If you have a runaway situation, it's almost unavoidable that if we have completely unchecked spread, that it will get to kids. And when it reaches that destination, that's when we'll really see the really bad, horrible outcomes of monkeypox. Well, early on, for example, in New York, when you infected a lot of middle-aged and elderly people who were hospitalized, and many died. So COVID, you saw the outcome very fast. For example, the deaths in New York City piling up, right? But I think monkeypox is the opposite. Early on, the spread, you won't see that many hospitalizations and deaths early on because they're in adults. But once it's unchecked, it will eventually reach the far reaches of our population and reach children. And luckily, schools are mostly out in most of the country, which is good. So hopefully there's not much school kid-to-kid germy transmission. But if we literally have 2 months of summer until this gets out of hand. So I think I want to just emphasize, this is why the emergency now. This is one of those things in which think of the frog. If you throw a frog in boiling water, the frog will quickly leap out to save its life and not die in the boiling water. But monkeypox, in certain ways, is the opposite. We're putting the frog in cold water and slowly heating it up to boiling, that the frog doesn't feel the temperature change. By the time it does, it will have boiled to death. And I feel like COVID is the dropping the frog into hot water, and you see the immediate outcomes early on in the New York City outbreak, while monkeypox is the slow boil that will eventually actually really reach the dangerous outcomes months down the line. And that's why I'm so worried about it. So we'll take one more speaker, I think Tiffany, but I think this is why this is much more worrisome, because it's much more silent and pernicious of a spread. And we're not going to see horrible outcomes early in the pandemic. We're going to see it much later, months from now, and we're going to really regret that we didn't take early action.
Go ahead, Tiffany.
Yeah, so I have a question about children contracting monkeypox. What ages are we talking about with children? And then also I have a question about essential workers. We saw during COVID how essential workers were working in close proximity to each other, especially in meat factories and manufacturing and all of that. Like, how can we keep essential workers safe during monkeypox, this monkeypox pandemic?
So the rough number in terms of age of children is about 10 years old. But as we know, there's no sharp number, right? It's going to spread out across, children. There are surely older children are also going to be strongly impacted. It's just that the likelihood of having a severe case is going to go down as you get to older ages. And in terms of the um, in terms of the
Workers?
in terms of the workers,
Yes.
the main thing to understand is that we have all of these transmission mechanisms that have a lot of evidence behind each of them. And we have to take precautions. If you have one type of transmission, then you take precautions for that, and you don't have to worry about the other ones. But if you have these several transmissions, physical contact, the the droplet and the airborne transmission, we have to worry about all of them. So we have to worry about not touching people. And in this case, unlike COVID, you can touch people you can touch things. If you wash your hands afterwards, you're supposed to be safe. In this case, the, the, the description of transmission includes the possibility of the virus going in through microscopic, i.e. unseen breaks in the skin. And that suggests that we have to wear gloves rather than rely upon washing of hands. And so physical contact is really has to be avoided. And the second thing is surfaces. So surfaces around, you have to avoid contact with them. If you're in a work environment, of course, that's very difficult. Wearing gloves for all day is its own toll. And then the last thing, of course, is that we have to do all of the airborne transmission precautions, ventilation and masking. And of course, we have to do these things in a diligent way. Monkeypox does not transmit nearly as rapidly as does COVID. And that's clear from the growth rate. But the fact that it doesn't, if the environment has someone in it that is contagious, there's one case where someone was transported to a hospital. They infected a taxi driver. They infected a ferry captain and a nurse that was involved in transporting them. And presumably, that gives a lot of evidence for airborne transmission. There's unlikely to have been direct physical contact since they knew that this person was infected, presumably. So we have to be worried about all of these things, and it's not that hard to get monkeypox. One shouldn't do all of these precautions in order to prevent transmission. So we have a huge challenge to do this in those spaces. That was true for COVID. It'll be true for monkeypox as monkeypox spreads. But the main thing is we need to have awareness of the fact that these precautions are important in order to protect children, in order to protect adults, of course, adults who may infect children. Just to say this clearly, children may have more severe cases, but that doesn't mean that adults don't have severe cases. The rashes can be extremely painful, and we surely do not want to wish that on anybody.
Yeah. And again, this is where exponential runaway cases is ultimately what will send more people to the hospital. Just like we try to explain to people during Omicron, you might think it's milder. It's not intrinsically milder, but you may think it's milder. But once you have runaway infections, that will ultimately what will overwhelm any hospital system. And I don't think it will immediately overwhelm a hospital system. Hopefully, knock on wood, it won't reach that level. But potentially it's much more severe and much more severe to the more valuable members of our society, which is children, in which we have to protect. And by more valuable, I mean like much more vulnerable. Okay, everyone's valuable, but I think children have so many years of life ahead of them, and we want to make sure that this slow boiling, slow rolling epidemic does not get any worse. And I think we're hitting that point which we have to act much more aggressively than we have ever before. And a lot of precautions are similar, but I think we need to be extra vigilant that hand washing is only a partial remediation. We have to be much more careful with actual surface contamination and on clothing and linens that have previously been contaminated. I emphasize, please check out our declaration. Please try to retweet it. I hope and pray to God that WHO declares a public health emergency international concern tomorrow, and it doesn't punt 2 or 3 times like it did in the early COVID pandemic. And hopefully we have learned from our history that we don't repeat our history. And of course, please join the World Health Network community. Follow us. And I really hope that we can make a change with this. And so thank you for everyone's support. And I think, just remember, I think protecting the children, the most vulnerable in our society, the most promising part of our future, is really, really the goal right now. And we're trying to look around the corner, and we are seeing a potential train wreck in months down the road when runaway infection has reached that point that a lot of children will be going to hospital. And I think, we don't want to reach that point where we look back and regret not acting faster. So thank you so much for everyone, and hope this was helpful for everyone. And thank you, Yaneer. And thank you, Katie.
Yes. Thank you, everyone, so much for tuning in. We will continue to hold Twitter Spaces, so stay tuned. We will be announcing those. We're also going to be monitoring the development of this new pandemic very closely, and we'll be posting updates on that. If you didn't get a chance to come up and speak and ask your question, please DM us, and we will get back to you with a response. We also be happy for you to join our network. We meet every day. We have a lot of volunteer opportunities and a really great community that we're just friends and support each other during this tough time. So come get to know us. We look forward to taking in more members. And thanks again for your time. And we look forward to speaking with you and connecting in the future. Have a great night, everybody, and stay safe.